low-grade lymphomas, such as follicular lymphoma, such as marginal zone lymphoma, for example. And the government has recently given us approval to use this chemotherapy drug called Bendamustine. And the reason why we really like it is because in certain kinds of follicular lymphoma, even within follicular lymphoma, there's certain different kinds there. It's actually probably the most effective chemotherapy drug we've got, and the side effect profile is extremely good. Okay, so we really like Bendamustine because it's new and it represents an advance for us, I suppose. Even though in East Germany they were using it even before the wall came down, and the rest of the world sort of discovered it after the wall came down. We didn't believe them for about 15 years, and then eventually someone caught on and they started doing clinical trials and realised that actually this drug's really, really good. So it's been around for a long time. Some of the others are much more aggressive types of therapy, such as hyper-CVAD or dose-adjusted EPOCH. These are kinds of chemotherapies you probably have to have while you're in hospital as opposed to coming into the day therapy unit. And we usually reserve those for really nasty kinds of lymphoma that are very aggressive. And then the other two here that I've got, ABVD and BIRCOP, they're regimes for Hodgkin's. And then there are some other regimes for Hodgkin's as well that we would use. Perhaps if you're elderly or if you're not, you couldn't tolerate some of those treatments, then we'd use some other ones for Hodgkin's. And then there are a myriad of other regimens that we might sort of call upon to try and treat lymphoma. Okay? That's right. But some combination of antibody, immunotherapy plus chemotherapy is generally speaking our mainstay for most kinds of lymphoma. So what's new? Well, Rituximab we've had for a long time, but there's a few new friends of Rituximab that have been made, and we'll go through those. Bendamustine, as I've already mentioned. Then there's this whole new class of drugs called PD-1 inhibitors, and I know some people in the crowd here have been on them. Rituximab vedotin for Hodgkin's and some other different kinds of lymphoma has been very exciting. And I know I've just put CAR T cells in there, not because they're we don't have access to them or anything like that, but I get a lot of questions about CAR T cells. So I'll just briefly touch on those so that you're all kind of informed and hopefully they make sense about what it is. So these are your CD20 antibodies. There's a few new ones around. So Rituximab's the first one, and then probably the one that's got the most evidence behind it now, and the newest and probably the best is this drug called Obinutuzumab or Gavisa. Now there's a few big studies that were done in this. So they did one with diffuse large B-cell lymphoma, and they swapped it out for Rituximab. So they did what we call a randomised control trial. So half the people got Rituximab and half the people got Obinutuzumab in combination with their CHOP. And for diffuse large B-cell lymphoma, they found it made no difference. Okay, so there was no advantage to getting the new flash, very expensive anti-CD20 antibody compared to good old Rituximab. Good old Rituximab stood up really well. What they found was that for follicular lymphoma, Obinutuzumab actually did make a very slight improvement to your what we call progression-free survival. Okay, so what that means is if you had follicular lymphoma and you got treated with, say, Bendamustine plus Rituximab, or you got treated with Bendamustine plus Obinutuzumab, the chance that your disease would come back sooner was higher if you got Rituximab. So your disease basically stayed in remission for a little bit longer if you got Obinutuzumab, but not a whole lot longer. So it was about 4 months longer, and the median time that it stayed in remission was quite a long time. It was about 6 years. Okay, so you could argue that obviously everyone wants to stay in remission for longer, but 4 months over the course of about 6 to 7 years is not a huge deal, especially when you consider the expense of the drug, which is one of the things that the government has to consider when they decide to fund something or not. So that's still not funded at the moment for follicular lymphoma. So we're still waiting on what the government says about that, but it is funded for other things like CLL. We've got access to it. Okay. So again, you've got to be a little bit careful about what you read. These new drugs like Obinutuzumab, it's this great new cancer drug, and it makes a really big difference. But it's important to actually have a look at, or at least ask your doctor about what the data is around these things, because some of them, even though they get a lot of press, and technically speaking, the headline might be correct, when you actually get down into tin tac, sometimes it's actually not that big a difference at all. Okay. So the big picture here is that Rituximab is still a really, really great drug, okay? And it makes a huge difference to people. And the rest of them are really just tiny improvements upon that, okay? What about PD-1 and PD-L1 inhibitors? Some of you will have been on... We've got a big clinical trials unit here which is using these drugs, and we're putting them up front with our CHOP and with some other treatments as well. We're using them in follicular lymphoma with one of our studies here. And many of you would have heard about these drugs before, and this is what the question that happened before about using... how do we kind of wake up the immune system to sort of find the cancer again? So one of the ways that cancer cells manages to avoid your immune system, okay, as we were talking about before, your immune system kind of the policeman is sort of, hunting around for cancer cells. One of the ways that the cancer cells manage to avoid the policeman is they put up this little marker called PD-1, or pardon me, PD-L1. Okay, so on their cell surface they put this thing up. Now the idea of that in a normal body is to tell the immune system to go away. All right, what's going on here is fine. We don't need you here. We don't need this inflammation going on here. The inflammation's making it worse. Please go away. And your T cell on its surface has this thing called PD-1, and when PD-L1 locks into PD-1, the T cell says, righto, nothing to see here. These are not the droids you're looking for, and it kind of moves away. All right. So one of the things that so the tumour cells, in a very naughty way, sort of co-opt this system in order to make the immune system go away. The classic one here is Hodgkin's. This is the main way that Hodgkin's disease becomes a cancer. Right? It actually it changes its genetics such that basically on its surface is this all the time. All right. What we can do now is we get some of these drugs, pembrolizumab and nivolumab, there's a whole bunch. There's about a dozen of them now, different ones that we can use. Is we can either block PD-L1 so that the tumour can't tell the T cell to go away, or we block PD-1 so that the T cell doesn't listen to the signal telling it to go away. So both of them work. Both of them work probably equally fairly well. And so the T cell can then go and kill, so that immune cell, which is the T cell, can then go and kill the tumour cell. All right? Sounds great. And in theory it is great, and it does work very, very well in certain diseases like Hodgkin's. Hodgkin's usually responds very, very well to chemotherapy as well. So we usually use chemotherapy first. And we still don't have access to these on the PBS yet, although it's probably coming for diseases like Hodgkin's. But it doesn't work for everything. Okay? And probably the reason is that not every cell, not every cancer cell uses this way to run away from the immune system. So not every cancer cell overexpresses this thing called PD-1. And in fact, most probably don't. But it's still an effective and an exciting and interesting new way of treating cancer. But at the moment, we tend to reserve these drugs for relapse. Okay, so if chemotherapy is obviously not working, then maybe if we can get access to it, we might be able to try one of these drugs. Okay, yeah.
How do you stop the T cells from attacking normal cells?
Yeah, that's a very good question. So that's one of the side effects from this treatment. It happens in 10% of people or less, so it's pretty unusual, but it does happen. Is that you can create like an autoimmune type of effect, so your T cells can attack your own body. Most of the time, those effects are really mild. So it's like a skin rash that goes away with a bit of steroid cream. Sometimes your liver gets a little bit inflamed, and various other things. Very rarely, sort of less than 1% of the time, is it a really serious life-threatening effect where such as your heart muscle gets inflamed, lung muscles get inflamed, various pituitary gland in your brain that produces certain hormones that keep your blood pressure high. They can get inflamed. So, and if those things happen, then that's, we really need to stop the drug, suppress your immune system right down again with some steroids, so they can happen. It's basically, we don't give these drugs to anyone who's already got an autoimmune condition because it might flare it up. and make it worse. But generally speaking, the vast majority of people who have these drugs have them without any problems at all. Okay. And probably the reason for that is well, it's not quite figured out yet, but how important the PD-1 system is in normal human physiology is it probably only gets switched on in abnormal inflammatory states, like autoimmune conditions, for example. Okay. All right. Is that one clear as mud? So these, again, you'll hear a lot about these. Chemotherapy is still best, and we tend to kind of maybe try and get access to these if chemotherapy doesn't work, depending on what different kind of tumour you have. But we do have a clinical trial here at the moment that's using these in the upfront setting, okay, which has been quite exciting. We haven't got any results yet, though. Eliza's going to talk about clinical trials, so I won't take too much of her talk. This is a new kind of different family of drugs called Rituximab vedotin. So what that means is this is an antibody, just like Rituximab, okay? But this is Rituximab. So instead of attaching to CD20, which is on most B cells, it attaches to something called CD30, which is predominantly on Hodgkin cells in Hodgkin lymphoma, but it's also on some T cell lymphomas. Rarely it's on diffuse large B cell lymphoma, but it can be. But when they first made this drug, Bendamustine, they realised it didn't work. And some clever person figured out that the reason why it didn't work is because as soon as it attaches to the outside of the cell basically just gobbles it up. Okay, it just gets internalised straight away. And so it doesn't do what an antibody is supposed to do, which is help your immune system to kill the cancer cell. So it just disappears into the cell. So then some clever person thought, well, if it's just getting sucked straight into the cell, why don't we use it like a Trojan horse? Why don't we put a little chemotherapy molecule onto it? So they attach this thing called vedotin, which is very similar to one of the drugs that you have in R-CHOP. So they just attached it, which is this little thing here. Okay? The yellow thing's the antibody, and this little thing's the chemo. And it gets sucked into the cell, and the cell goes, ha-ha, I've gotten rid of this antibody, but then all of a sudden, bang, the chemotherapy does its thing, and the cell dies. Okay? So that's been a really effective treatment in Hodgkin's disease. There's been a few studies in this. So relapsed Hodgkin's disease, it seems to work pretty well. It also works pretty well in upfront Hodgkin's disease, and in fact it improves if you swap it out for one of the drugs in ABVD, which is the most common Hodgkin's regimen. It actually does improve the progression-free survival, so how long you sort of stay in remission. But we're still waiting for more data about that as well. And it's approved for Hodgkin's in relapse, but not upfront yet. Okay. Very expensive. Most of these new drugs are very, very expensive. We're talking, many thousands of dollars a month. Okay, so they're not things that we can just sort of throw around lightly, and they're not things that we can always get access to, unfortunately, from a funding perspective. But this is an interesting new concept, and there are new drugs very much like this that are being used in specific for other markers on other cells. Okay. So there's a new one called Rituximab vedotin, which attaches to a thing called CD22, which is on most B cells. So hopefully that will make it, if it's as effective as Bendamustine, then that might make it applicable to a far wider range of different kinds of lymphoma as well. So there's a lot on the horizon. All right. Now what about CAR T cells? Sorry, that picture hasn't come out very well at all. Okay. I'll try and make this very as straightforward as I can for you. Who's heard of CAR T cells? Put your hand up. A couple of people. Okay. So these are very, very much in the research space still. There's been a couple of large studies in lymphoma and a few studies in a type of leukemia, a type of what we call BALL. And it was recently approved in the United States by the FDA for treatment of those two conditions, diffuse large B-cell lymphoma and BALL. And essentially what you do, this is the future is now kind of stuff. It's really very, very interesting. It works on this theme of immunotherapy, but what it's trying to do is basically re-engineer your body's own immune cells and then give them back to you so that they're ready to fight the cancer. Okay? So what you do is you go on an apheresis machine. Has anyone been on an apheresis machine before? They take your stem cells, okay? It's like, look, if you needed a stem cell transplant, or if someone was going to donate their stem cells to you, they'd have to go on an apheresis machine, just like you would if you're donating blood at the Red Cross and they're going to take plasma off, okay? Same thing. They take some blood out. They take the cells, the lymphocytes, these immune cells, out, and they give you the rest of your blood back. Put those cells in a bag, put them in the freezer, send them to the lab. The lab then, in a very clever way, we actually use, and this is really interesting, HIV is a terrible disease, but it's taught us how to do this. So we use a virus like HIV, it's not HIV, but a virus like HIV, to bring a new piece of DNA inside the cell. By so doing, that then makes your cell then makes a new protein, and that protein is this thing here. It's called our CAR, chimeric antigen receptor. You know that CAR, that protein, then what its job is to hunt down this particular marker that is found on every single B cell in your body, including all of the cancer cells, and it attacks it and kills it. So once they've done that, they make them grow inside the lab. They put them back in a bag, they take them back to you, and they put them in. They reinfuse them. So it's your own stem cell product that's been given this new, different kind of DNA. Okay? Amazing. Works well, though not in everybody, for this kind of disease. Costs about $1 million. So it's not a panacea. It has a lot of side effects. Okay. But this is a very, and at the moment it's currently only being done in the United States, and it's only available on clinical trials, and they've treated about 250 people in the whole world with this, okay, for this disease.
How often do you have to have the treatment?
Usually, well, if it works, once.
Once,
Yep.
one only.
Yep. So they would only use this in really refractory disease, so you've had many different kinds of chemotherapy and it all hasn't worked, okay? That's at the moment, because the side effects are quite significant. Okay, you can imagine this gets rid of all of your B cells, even the good ones, even the normal ones, and if it works properly, they never grow back. So what that means is that you need to have antibody, because B cells, their normal job is to make antibody, and so you need to get antibody from donors in the form of something called IVIG, and you need to have it once a month for the rest of your life. Okay, it's better than having cancer though. Yeah.
I had a stem cell transplant.
Yeah.
And 17 years later, I was okay. I mean, it was tough trying to get myself better. And now lymphoma's come back, but it was a different one. That was mantle cells.
Right. And now you've got a different one. That's very unlucky. So two different kinds of lymphoma so far apart. Yeah. We do occasionally see things like this, and whether or not there's a, the cells have a common origin, or whether you've just been unlucky and you've been struck by lightning twice, it's very hard to tell. But probably in your case, it's that you've been struck by lightning twice.
But that mantle stem cell transplant is pretty tough.
Yeah, it is. This is not stem cell transplant. This is slightly different. So there's very little chemotherapy involved with this. Okay. Now I'm nearly finished, but I better move on. This is what I've already told you. So they take your cells out, engineer them, and then give them back. And then that's all I've got to say, because Eliza's got to come up next, but we might have a minute or two for questions.
Yes.
But basically, our therapy now is a whole lot better than it was 20 years ago. Chemo immunotherapy, what we've got now, still serves most of our patients extremely well, but there is a whole lot of work and a whole lot of research going on into how do we make our lymphoma treatments better, less toxic, have less people relapse, and so we've got better options if and when people do relapse. One thing I didn't talk about was those targeted therapies. There are a handful of those floating around, but for the sake of time I didn't, but I'm happy to take any questions about that.
Yes. Just got a question. You were talking about genetic mutation at the start. I had breast cancer 4.5 years ago, and then diagnosed with follicular lymphoma at the start of the year. And I actually wanted to get genetic testing done. And I just seemed to go around and around and around in circles between people in Melbourne and Sydney. People wouldn't get back to me, and after wasting a huge amount of time on it. I basically gave up. Why is it so hard? And if it's not so hard, where should I have gone?
Yeah, no. There's a handful of reasons why it's hard. First of all, because probably follicular lymphoma and breast cancer don't really have a common genetic basis, so they're actually very, very different tumours. The chance that, so breast cancer happens in about, I think it's, 1 in 8 or 1 in 11 women over the course of their life. So it's pretty, so it's a pretty common thing. So the higher likelihood is that you just, again, you just got 2 different cancers that don't have a genetic basis. Most of the time, genetically based cancers present when you're younger. Okay, so if you start getting breast cancer when you're 30 or you're 40, that's when we really start to think about doing genetic testing. The reason why we don't tend to do it is, number one, you've got to know what you're looking for. Number two, if you don't know what you're looking for, then you're talking about what we call whole exome or whole genome sequencing, which basically looks at every single gene in your body. When you do that, you can find a whole lot of things that you don't want to find that might impact on other things, so that has implications for your siblings, for your children, for potentially for things like their health insurance. So if you find a gene